Good evening, everybody. Thank you for joining us this evening on this BTOG Essential update on supporting patients with thoracic malignancies. I think probably one of the most important subjects we've done in this webinar series over the past more than a year. We've been doing it. My name is Tom Newsom-Davies. I'm a medical oncologist at Chelsea and Westminster Hospital. As you can hear, I'm slightly losing my voice, but that's okay because I'm not going to be the guy doing all the talking. I'm delighted that you joined us this evening. Move the slides forward with my clicker, which is hopefully going to work. There we go. We have sponsorship of these events. We're very grateful to our sponsors for allowing us to bring this webinar to you for free, but to reassure you that our sponsors do not have any role or in the planning, content or delivery of any of our material presented. Also welcome from the BTOG bosses, otherwise known as Dawn and Gina, as you can see in the pictures here. They haven't changed year on year. They are unchanged in appearance, which is a wonderful thing. If you have any questions regarding BTOG, please contact the executive team of Dawn and Gina respectively in this email and website accordingly. So there are times for questions and answers. Please make use of that by typing your question via the control panel. I can see on the screen on my left here, they crop up and I can ask our esteemed expert panel accordingly. If you're feeling brave, you can stick your name in and where you come from. And if you're feeling shy, you don't need to. We'll send you an email for feedback. As you know, we all have to do feedback permanently. You can't do anything without feedback nowadays. But we're really grateful if you could send us feedback on what works and what doesn't. And this is our agenda. So our agenda, we have three expert people speaking to us. The first we have is Rachael English. Rachael is a specialist nurse in the interventional pain unit. Oh, the slide's moving forward. Could we just move back a bit, guys? There we go. Is a specialist nurse in the interventional cancer pain unit at the Beatson. Will be followed by a Q&A session. Shortly after that, we will welcome Marie Fallon. Marie is a consultant in palliative medicine at Edinburgh Cancer Centre and also the chair of palliative medicine at the University of Edinburgh. And she'll be talking to us about breathlessness and new developments, management thereof. And then finally, but absolutely not least, we have Barry Laird, who's a senior clinical lecturer in palliative medicine at University of Edinburgh and also a stalwart of the BTOG steering committee. We'll have some questions after that, and we are then all done and dusted by 6:30. So we'll move swiftly on to Rachael. Rachael, thank you very much for joining us. And to remind people, if you have questions, put them in the control panel, and I'd be delighted to bring those up with Rachael in her Q&A session. Rachael, over to you.
Hi there, thanks for having me tonight. So my name's Rachael English and I'm the clinical nurse specialist for the Interventional Cancer Pain Service, and we're based at the Beatson in Glasgow. And this evening I'm going to talk about interventional pain management for thoracic malignancies. So first of all, I'm going to give a bit of background to our service and our role in managing difficult cancer pain. And then I'm going to go on and provide an overview of cordotomy as an intervention for the management of pain associated with thoracic malignancies. So why do we have an interventional cancer pain service in the first place? So we know that not all cancer pain is adequately controlled, and around 20% of patients with cancer have poorly controlled pain. And research would suggest that between 5 and 15% of patients might actually benefit from an intervention to help their cancer pain. So since 2007, the Interventional Cancer Pain Service has been offering interventions for cancer pain at the Beatson in Glasgow. And we operate as a fully multidisciplinary team, each of our members with different valuable roles in patient assessment. And our service became regional in 2015, covering the 4 health board areas within the west of Scotland. So we're based at the West of Scotland Cancer Centre, which allows us to have access to inpatient beds there. We have designated theatre access once a week, and we also have access to outpatient clinics for the assessment and ongoing care of our patient group. As I said previously, we're a fully regional service, and we accept referrals from palliative medicine consultants and colleagues and oncology colleagues from the kind of 4 main health board areas within the west of Scotland, but we do also consider referrals as extra contractual referrals out with the area. We have designated sessions from chronic pain, palliative medicine. We've got myself, the CNS for the service. We've got a specialist physiotherapist, clinical psychologist, and pharmacist within the team. So the aims of our service are very much to provide support for patients with difficult cancer pain, and primarily those whose pain is not properly controlled by using the conventional analgesic measures, or whoever, for patients whose pain control is limited by unacceptable side effects from their medications. And we aim to provide a robust but flexible multidisciplinary assessment to help us guide appropriate access to procedural interventions. And we very much look to ensure that we're performing the right intervention at the right time for the right patient. We also aim to support fitter cancer patients to achieve a better quality of life before their end of life stage. We look to provide a patient-centred care package across all healthcare sectors, and to provide a service which adheres to national recommendations and that operates within a transparent and robust clinical governance framework. So this slide here shows our kind of MDT approach with the patient in the middle, really. We're very much a unique service within the UK, and we take a very much MDT approach to patient care, where each member of the team's opinion is taken into account when deciding if an intervention is appropriate or not for a patient. So like I said before, we have input from palliative medicine consultant, looking very much at whether the pain could be managed with less invasive measures. We have input from chronic pain, who kind of look at the more technical aspects of the pain and whether or not an intervention is appropriate. We have a designated pharmacist who works with the service. We have 1 session a week from clinical psychology, and where in the past we've found perhaps a physical intervention wouldn't be appropriate for a patient, we've been able to, if it indicated, involve Lauren, or a clinical psychologist, in offering kind of ongoing psychological therapies for our patients. We've got specialist physiotherapy and CNS input. This slide here looks a bit complicated, but this is more or less our kind of referral pathway. So new referrals to the service are usually generated from palliative medicine colleagues or oncology colleagues. And we would then, as a team, discuss whether or not we felt appropriate to appoint the patient to clinic. If it was felt appropriate for them to be seen at clinic, and we do very much try to see most patients, it's always very helpful to kind of properly tease out what's going on with them. They would be seen, first of all, usually by palliative medicine consultant and chronic pain, along with physio. And if it was felt at that point that, dependent on what intervention was deemed to be suitable, may well offer a second assessment, and that would be where they would be seen by myself and perhaps by clinical psychology. And then we would have a discussion as a team as to whether an intervention was felt appropriate, and if it was, what intervention would be deemed appropriate for the patient, depending on the location and type of their pain. So this is a kind of variety of patient information leaflets that we have developed, and just showing what interventions we actually have on offer. So prior to the pandemic, I would have said probably intrathecal drug delivery was one of our kind of most popular interventions, whereby a patient would undergo a trial of intrathecal drug delivery within the Beatson and perhaps proceed on to an implanted intrathecal device to help control pain, typically from the waist down. We offer celiac plexus blocks, generally for patients with kind of upper abdominal pain, mainly associated with pancreatic cancers. We offer cordotomy, which I'll go on to talk about in more detail shortly. And we also offer intrathecal neurolytic blocks, but they are generally for patients more kind of in the end stage of life. So cordotomy was prior to us having the service at the Beatson for cordotomy. patients who were assessed at clinic and felt appropriate for chordotomy had to be travelling down to Liverpool to have the procedure carried out. So percutaneous chordotomy is basically, it's a specialised injection into the side of the neck, which is performed with the patient awake. The spinothalamic tract is located and lesioned using a radiofrequency electrode, and the aim of it is to relieve one-sided pain below the neck. So it is a selective radiofrequency destruction of the spinothalamic tract on one side of the cord, and it does give selective loss of pain and temperature unilaterally below the neck and doesn't cause any other sensory or motor deficit. It's very effective for chest wall pain, for example, mesothelioma, lung cancer and breast cancer. And it offers a permanent form of pain relief. And since the pandemic, we've found that it's probably been our most common intervention that we've had on offer. So the service, chordotomy service at the Beatson was launched in March 2017. And we have a specialist database for the interventional cancer pain service where we record data on patients who've been referred in and treated by the service. And since our launch, we've had around 86 patients referred with chordotomy in mind. And of these 86, 38 patients have been offered and consented for chordotomy, with 35 of them actually proceeding to chordotomy. 3 procedures were abandoned in theatre, and that was generally due to difficulty in positioning of the patient. And of the patients who've undergone chordotomy, 24 of them had a thoracic malignancy. So on average, around 43% of patients referred into the service with chordotomy in mind were listed for the procedure, and these graphs just show the yellow bar showing referral numbers with the green showing patients who were listed for the procedure. So multiple reasons for why we might not go ahead, might not list patients for chordotomy. So around 7% of patients who were seen and assessed for chordotomy and offered the procedure unfortunately didn't go ahead because their condition deteriorated from referral. Around 10% were found to not be medically fit at assessment, and that can be for a variety of reasons. Generally due to the kind of nature of the disease would be if they were already had a degree of respiratory compromise or kind of overwhelming frailty. Around 16% of patients who were referred, it was felt that their pain wasn't amenable to the intervention, so perhaps out with the area that the chordotomy would cover. Around 5% felt not technically possible. Around 9% pain not significant enough to kind of outweigh the risks of the chordotomy. And about 8% of patients referred with chordotomy in mind actually declined the procedure when we went on to kind of explain it in more detail to them. So indications and contraindications for chordotomy. So it is generally for patients with unilateral, so one-sided cancer pain, and the kind of main areas that it would cover would be below the shoulder and above the knee. We have had patients who's had pain further down the leg, but we definitely find that it is less effective for pain out with these areas. Generally, patients would have pain which was uncontrolled by their conventional methods, or it was felt that it was likely to become so over time. Patients would generally have a life expectancy of less than 2 years, and that's because research, although we haven't had any experience of it with our service, research suggests that over that kind of greater than 2 year period, there could be a degree of nerve regrowth, which could cause the pain to recur and could potentially be worse than the original pain. Patients need to be able to lie flat and still in a kind of in theatre for up to an hour, and they need to be willing to undergo an awake procedure, although we do give some light sedation and some analgesia in theatre. We very much encourage early referral to the service. If you feel chordotomy is something that you think would be appropriate for your patient, we do encourage early referral into us. And just recently we've found that a kind of new contraindication would be patients who were oxygen dependent at rest. Why do we ask for referral earlier? Well, we found in the last year or so that it's, you know, very not an appropriate end of life intervention. And our experience has led us to realise that frail patients generally are less likely to tolerate the procedure and less likely to recover well. So in the kind of couple of days post-op, generally patients can feel quite under the weather and kind of a generalised sort of flu-like symptoms, fatigued, and also there is a kind of there have been patients who've kind of reported leg weakness post-op as well. So we like to see patients as early as we can, and also we know with the type of patient group that we're looking at, chordotomy can also worsen pre-existing respiratory failure. So pre-op considerations, preparations. So as with most situations now, prior to admission, patients need to have their COVID swab before coming into the Beatson, and we would generally admit to the Beatson 24 hours prior to the procedure. If the patient's on anticoagulants, we have a specific anticoagulant policy for our service, and would be looking to have them stopped prior to the procedure. Because if the chordotomy is successful, it provides almost instant pain relief. So we look to make analgesic changes, particularly to their opioids on admission. Patients who are on long-acting analgesia, so we would look to get them converted onto shorter-acting analgesia, just so that it would be out of their system quicker post-op. And we look to reduce their opiates on admission. On the morning of the procedure, we would look to reduce their opiates by about 50%. We collect data, as I've already said, we have a specific database for the service. So on admission, we would be collecting 4AT and BPI measures from the patient. They would have physio review on admission to the Beatson, and we carry out kind of baseline sensory testing. Goal setting is very important too, as we like to know what patients' goals are from the procedure, and we set goals as a team as well. And these are reviewed post-op. They'll be consented for the procedure, and they would fast from 12 midnight. So this is just a shot of what actually goes on in theatre. So the patient lying flat on the theatre trolley, and their head supported in a kind of a cradle at the back there. So it's quite a busy theatre, quite a lot of people involved. So we've got radiography, our chordotomist, theatre staff, and I would generally go into theatre with the patient as well, just as a kind of support to them, and kind of you know, just monitor their analgesia while in theatre. And that's just.
I'm going to give you a 2-minute warning. Sorry, we're running a little bit.
Okay, sorry. Yeah, so this is just an example of where the needle goes. So it's generally on the side opposite to the pain and just below the ear there. And we perform motor testing while the patient's undergoing the lesioning, just to make sure that we're not causing any damage to their motor function. Post-operatively, the patient's on bed rest for 24 hours, because we do know that it can cause leg weakness, and we would have physio assessment the day after theatre, get them up on their feet and assess their mobility. And we would continue to down titrate their analgesia, so their opiates are the first things that we try to kind of cut down, but we do also then look at their adjuvant drugs as well, and look to try and cut as many of them down as possible. And we do aim to get them home within 48 hours post-procedure. Data collection, kind of routine data collection for our service. We look at collecting BPI, 4AT, look at functional measures for the patient, goal setting, medications, and sensory testing. And this is our kind of physiotherapy assessment, looking at their pre-chordotomy function and power, and also their sensory function as well. And these are repeated. They're done pre-op and then post-op, and then at 2 and 6 week post-op follow-up. These next slides look at pain scores, so kind of outcome measures for the service, and you can see here that in general, you can see that the pain scores for patients would indicate that it's pretty successful, and that we generally see quite a decline in their pain scores from referral through to discharge. And these are then the reduction in pain scores are then looks to be sustained at 2 and 6 weeks post-op. So just a kind of brief case study of one of the patients which we had referred to the service was a 67-year-old man with a background of mesothelioma, and was referred in with a difficult pain in his right shoulder and scapula, which was greatly impacting on his quality of life. He set goals on admission to the Beatson, which was to improve his pain control, reduce the side effects of his medications, and to be able to take part in more kind of hobbies and pastimes, which he was unable to do because of his medications. And these are just some shots of his pain scores post-op. So you can see on at the beginning referral and pre-assessment, pain scores universally quite high, but you can see quite a dramatic reduction in their pain score, in the gentleman's pain scores post-op and at discharge. As I say, we follow the patients up at 2 and 6 weeks post-op, and you can see here that this gentleman had a sustained improvement in his pain scores at 2 and 6 weeks post-op. And in terms of his medication use as well, the white line here shows is the OME for the gentleman. So at assessment, his OME was 1,600 milligrams in 24 hours. And at discharge, we were able to have dramatically reduced his OME down to 150 milligrams. Slight increase at 2 weeks post-op. But again, if I remember, this gentleman was kind of in kind of last weeks of life when he was seen by the service. So that was to cover pain out with the cordotomy area. But as you can see from his medication use, there was a dramatic reduction from assessment to a discharge and 2 and 6 week post-op.
I'm going to have to ask you to wrap up that. I'm really sorry. It's just we've got to cover because if you could perhaps skip to the conclusion, I'd be really grateful.
Yeah, no problem. So just in terms of areas for development and points to consider as a team. So at the moment, we're working on a kind of more standardised post-op follow-up assessment tool. We have developed more robust guidance in conjunction with our pharmacy colleagues on the post-op reduction of adjuvants, and very much encouraging local palliative care teams to continue to reduce adjuvants where possible in our patients, and also just continuing education to referring teams to encourage early referral into the service to try and improve outcomes for patients with difficult cancer pain. And sorry, it was a bit rushed at the end there, but if there's any questions, I'm happy to take them now.
Thank you very much, Rachel. That's fantastic, and I have learned a huge amount. There certainly will be. What I'm going to do actually is just move on to Marie straight away. That's okay in the interest of time. And if people do have questions, you use the Q&A thing, and that tends to come through in a couple of minutes' time. So, Marie, if you're okay for us to move straight on to you, and we're now going to talk about breathlessness. Thank you very much for giving us a talk.
Thank you very much, Tom. Thank you for having me. So I'll hopefully bring up the first slide. I'll try again. Thank you. Okay, so I'm going to cover breathlessness. Clearly, it's going to be largely focused and relevant to patients with breathlessness due to advancing cancer. But within the presentation, I'm going to draw in other causes of breathlessness in chronic life-limiting disease, such as COPD, heart failure, interstitial lung disease, because obviously with large numbers of comorbidities, this becomes very relevant to many of our cancer patients as well. So I'll try this clicker. I'm not sure it's working. Can you just advance the slide? That's super. And I apologize if you can't see this. I'm just going to do a little bit in the background, and then we're going to move on to pharmacological management, non-pharmacological management. I'm going to discuss what we understand about central mechanisms of breathlessness, and talk a bit about our clinical trial of opioids in chronic breathlessness. So as a symptom, it's clearly very frightening and also debilitating on many levels. And we do know that in patients with chronic progressive diseases, including lung cancer, certainly more than 90% of patients will have breathlessness. In things like heart failure, maybe about 80%. The actual breathlessness perception is like any symptom such as pain. It comes down to perception in individual patients, and that perception is very much processed in the cortical areas of the brain, with significant input from centers of mood, particularly anxiety, sleep deprivation, and depression. And we have something, an endpoint that's called interoception. So we have central networks that actually interact, feed into each other, and the output of that is the subjective sensation of breathlessness. We do know that physical exertion can generate breathlessness, but actually central blunting of breathlessness perception can allow more physical exertion. And we see that with the naloxone experiments. You actually give naloxone and it increases exertion-induced breathlessness. So there's absolutely no doubt that opioids, opioid receptors, and the network within the brain, drawing in more than pathological processes, causing triggering of the endogenous opioid receptors, but also anxiety, etc., will lead to this endpoint for individual patients. Next slide, please. So the current evidence base, looking at opioids, which has really been the mainstay of management until recently, there's been no medication actually licensed or registered for chronic breathlessness. Last couple of years in Australia, low-dose opioid has in fact been licensed for chronic breathlessness in the short term. In the UK, clinical practice is very variable. Opioids are prescribed by some, but there do remain concerns about safety and uncertainty about efficacy. And sometimes we just lack that conviction of the right path forward for individual patients. And of course, this comes down to the very poor evidence base. Next slide, please. So evidence gaps, I'm going to show you some systematic reviews, mostly patients with COPD, but again, these are relevant. There are some in cancer. The longest reported placebo-controlled follow-up study is 45 days, and that was in heart failure patients. And the MABEL study, which we developed, which is a parallel RCT placebo-controlled of low-dose morphine and breathlessness funded by HTA, is really to address definitively, hopefully, effectiveness, safety, optimum dose, and long-term effects. And within this study, we have embedded some qualitative work that we're hoping that would very much help with any appropriate implementation of study findings. Next slide, please. This is really just Forest Pot looking at meta-analysis of effectiveness of opioids in reducing breathlessness. Really because of the lack of taking on board the different study designs, particularly crossover, these results have been attenuated and difficult to interpret. Next slide, please. Negative trial. David Carroll in Australia published a negative trial in Thorax last year. It was 7 days of oral low-dose sustained release morphine versus placebo for chronic breathlessness. There was no benefit with the primary outcome of breathlessness right now, but methodological issues within the study in retrospect have been very helpful in helping us move forward with our study, with the MABEL study. So one key thing is, because of slow recruitment, eligibility criteria were expanded. That old chestnut where we often expand and then, of course, it's the wrong thing to do. So patients with a lesser degree of breathlessness, MRC level 2 as opposed to the initial 3 and 4, were included in the study, but we do know that it's patients with more severe breathlessness that tend to benefit from opioids. There was, interestingly, no measure of physical activity. In the MABEL study, what we've actually got is breathlessness improvement as one outcome, one primary outcome, and a separate primary outcome is function. And obviously this complex relationship between the perception of breathlessness and physical activity has to be taken into consideration, because patients may in fact end up with the same amount of breathlessness following treatment with morphine, but actually they're much more physically active, and for them that's an okay trade-off. And the other thing in the study, interestingly, was there was much greater use of immediate release morphine in the placebo arm. Next slide, please. More recently published in JAMA was a COPD multi-site placebo-controlled RCT, 4 weeks. It was 10 milligrams of sustained release morphine. Patients could titrate after the second week to TDS. And we could see here that there was actually an improvement using the COPD assessment tool in the primary outcome. And again, the subgroup of patients who benefited most was those with more severe breathlessness, MRC grades 3 and 4. Interestingly and importantly, there was no excess in serious harms, including respiratory compromise in active versus placebo. Next slide, please. So one of the issues is, of course, if you're a clinician, you have an opioid-naive patient, they're breathless, what dose of morphine do you actually use? And we do know that in the absence of pain, the doses of morphine for breathlessness are generally going to be much lower than you would be using for a patient with significant pain. But there's been a dose-finding study way back a decade ago, and it was interesting in that over 90% of patients actually had a response by 20 milligrams of morphine a day. And if you think of that and think of, 50% had an improvement of a total of 10 milligrams per day, it very much resonates with our clinical experience in that low-dose opioid is often very adequate to control symptoms in pain-free patients. And you can see that if you have a patient on maximum dose of codeine, 60 milligrams 4 times a day, is equivalently significantly more than actually this amount of morphine required to control breathlessness. But again, there's quite a lot of fear and anxiety about this, particularly if you have comorbidities. And of course, many patients with lung cancer, for example, will have COPD and maybe cardiac issues as well. Next slide, please. So again, looking at morphine safety, just to summarize between this and next slide, please, the following slide, that there's no excess of admissions, looking at the thousands of patients put together from RCTs of either opioids or opioids and benzodiazepines. So far, it would seem to be that with the low dose of opioids, that there is safety, but this clearly needs further evaluation. Next slide, please. So again, this just summarizes really the slides that I've shown you before, but looking particularly, everyone's always very interested, particularly respiratory clinicians, in O2 and CO2. So there was a statistically significant but clinically non-significant increase in partial pressure CO2, an insignificant reduction in partial pressure O2 and O2 saturation when we looked at well over 1,000 patients between 67 studies. So the bottom line here is there was nothing clinically relevant, although you can see here statistically significant increase in partial pressure CO2. And, you know, you're looking at one case report in a cancer patient who needed respiratory support out of this large number of patients. And of course, we don't have the clinical details on this. We don't know what else was happening, renal function, etc. But certainly the general direction of this information is very supportive of safety. Next slide, please. Again, Carol, who's done a huge amount of work in this area in a phase 4 study. Again, it's just a small number of patients, but there were no patients on maintenance opioids who actually presented to healthcare providers or when stopping this opioids coming out of the study actually had any opioid withdrawal. Next slide, please. So it would seem to be, so far with the evidence we have, that we do know that morphine has a well-known safety profile from other symptoms. And with the information we have, we do need a bigger, better designed study looking carefully at the equipoise of side effect profile in opioid naive patients. But the same principle applies to prescription morphine as applies to any of the drugs I've mentioned here. It's obviously review, fine-tuning, titrating, managing, but optimally preventing side effects. Next slide, please. So herein is the crux of the issue. And we've done a lot of work with pain and fMRI, and our understanding of the relationship between the physical stimulus, the input at higher level of anxiety, depression, sleeplessness, etc., and what we have with the coming together of these pathways is then what we refer to as interoception, and then the translation for the individual patient into the subjective sensation, whether it's pain or the same that we've come to appreciate happens with breathlessness. So if you have a patient where they're anxious, managing that breathlessness is actually going to be very much more difficult. There will be direct input into the endogenous opioid receptors at cortical level, and very much at that input at brainstem and descending inhibitory pathway level. And so the real input that will go back to the lungs will be exaggerated. And this is why over the years, yes, we've been interested in opioids, but we've been very interested also in the total management of the patient, their anxiety, their fears, their depression, empowering them with what to do during acute episodes. And this is where breathlessness clinics and using lots of non-pharmacological input with breathing, handheld fans, all of these things have been shown to be effective. It's really important that they're brought into the comprehensive management of breathlessness. But interestingly, for many, many decades, clinicians have been prescribing antidepressants at night for breathlessness. Started off initially with COPD patients, tiny doses of amitriptyline, like 10 milligrams at night. This very much came into cancer care and has been expanded. And we now understand a lot more about serotonin and the role in breathlessness. I won't go into that in great detail, but there is currently an RCT underway looking at mirtazapine in breathlessness in patients with cancer. And these are some interesting and useful websites here. Next slide, please. So I mentioned the non-pharmacological interventions. It can be face-to-face at a clinic. Obviously, during COVID, that's been attenuated. Can be internet-based with a clinician. Or in fact, there's a lot of useful self-guided internet-based work. One of the things that I've added to in the non-pharmacological interventions in the past has been acupuncture. I used to insert indwelling studs in the sternum, and now these days we can actually teach patients how to use tiny little indwelling acupuncture needles that they cover over with micropore, and these can remain indwelling for about 4 or 5 days. And the idea is when the patient feels breathless, they can actually massage these little studs or the indwelling needles. And this is something that we're very interested in exploring further on a research basis. Next slide, please. So moving on to morphine, a bit more on that and how we should prescribe that. Next slide, please. The MABEL study. Now, some of you listening at your centres may be signed up to the MABEL study. We do have about 5 open, and we've struggled during COVID with R&D approval to keep on schedule, keep to time. But we are improving, and we've done well in the last week with opening another 2 centres. But this is a parallel group, double-blind, randomised, placebo-controlled trial, comparing the effectiveness and cost-effectiveness of low-dose oral modified morphine versus placebo on patient-reported worst breathlessness. And this worst symptom is really important because it's often the worst breathlessness, just like the worst of any symptom, that actually impacts mostly on quality of life. Function is up there important in the outcomes because clearly that's a shifting dynamic process between breathlessness and function. Next slide, please. One of the things that we're very keen on in this study is to harness patient and carer and prescriber views. And our experience in the past of patients taking part in palliative care studies has been very positive. And this qualitative study I've put up here, this actually looked at patients who'd taken part in 2 of our double-blind placebo-controlled RCTs for pain, and we were particularly interested in interviewing patients who didn't have an improvement in their pain. And the sorts of themes that came back was the opportunity to be altruistic, to have legacy making, can potentially contribute to the general well-being with the input from the research team, which overlaps with additional support. And we very much feel that it's absolutely ethical to offer patients the opportunity to take part in symptom control studies. Next slide, please. The take-home messages really are that there's a very poor evidence base for breathlessness. The greatest evidence base is probably with the opioids. We really need to understand doses. We need to understand which patients for which dose, and we need to absolutely draw a line under, are there unacceptable side effects or not? Final slide, please. And this is just the researcher who's heading the sub-study looking at interviewing patients. Thank you very much.
Thank you, Marie. That's extremely helpful. Breathlessness is such a common symptom and is a thing I'm probably asked about most by my patients after pain. We're going to move straight on to Barry's talks, and then we're going to do all the questions at the end, I think would be best. So Barry, thank you very much for bearing with us. You're going to talk to us about cachexia, the other of the third a third of the really important symptoms. Thank you very much for joining us this evening.
Thanks, Tom, for the kind introduction. And so, my name is Barry Laird. I'm a consultant in the Edinburgh Cancer Centre, working with Professor Fallon, and an academic at the University of Edinburgh. This is the hospital, the Western General. Just trying out slide clicker to work. Next slide, please. That's me got it. I think it's working out perfect. So this is a common scenario that I'm faced with in my clinical practice, and I suspect a lot of you are in your clinical practice, patients losing weight. So this is a gentleman asked me, do you have anything you can give me, doc, to stop me losing weight? He dreads to going to the table for food, and it's a really common scenario that the partner or the spouse of the patient is angry and is stressed because this patient is losing weight and they're not eating. And quite often, patient's family will try to make them their most favourite meal, and they'll spend a lot of time doing something nice, and the patient really can't face eating it. So why is he losing weight? That's what he asked me. Why am I losing weight? Well, it's a condition called cachexia, and it's really important that we're talking about it in the context of lung cancer and BTOG, because with the only other cancer would be pancreatic cancer, but cachexia is probably the most common in lung cancer of all solid tumours. We know that lung cancer 5-year survival rate for non-small cell is about 20%, and cachexia really is a critical factor in this. Studies have shown that about 60% of patients show significant weight loss at diagnosis and is present in approximately half of incurable lung cancer patients. Now, we're saying present in approximately half, I'm talking about patients with a weight loss of 5% or more, and that's not a huge amount. In terms of what that means for people, well, actually, if you see, look at this graph here, this is different Kaplan-Meier survival curves for patients at various stages in their cancer journeys. This is the same cohort followed up here. So the non-CC are patients that don't have cancer cachexia, and the CC are patients with cancer cachexia. And you can see here, these are all patients with non-small cell lung cancer undergoing systemic anti-cancer therapy, that the impact of cancer cachexia affects their survival in a very negative way. So it's really meaningful for the patients that we look after, lung cancer, that cachexia is not just something that happens, that we just sort of accept as tide and tide of the parcel, that cancer cachexia actually impacts survival in these patients. I do believe there's a bit of a degree of therapeutic nihilism in cancer cachexia, and that it's been around for a long time, and we almost sort of accept it as part and parcel of lung cancer. But hopefully in this very short talk, I'm going to give you some ideas of things that you can do in your clinical practice that may change that. Now, this was a study done at the Marsden almost 20 years ago now, and what it showed was that patients with non-small cell lung cancer had reduced survival when they had degrees of weight loss, but it affected their ability to have cancer therapy effectively. So they had less cycles, they had more treatment delays, more side effects, and less symptomatic benefit from chemotherapy. So cancer cachexia is really not just about loss of weight or loss of appetite, but it actually impedes how well people like Tom and his colleagues can deliver systemic anti-cancer therapy effectively, and that's why it's so important. In terms of what we're talking about when we talk about cancer cachexia, I thought it's interesting just to spend a few seconds on the semantics. So, if you look at the top picture here, this is what we call sarcopenia, so depletion of reserves, and this is generally what you see in the aging process. As people get older, they lose muscle, and that's sarcopenia. Taking it a stage further, when people have sarcopenia in combination with decreased food intake, that becomes malnutrition. But to make it cachexia, really what you have is involvement of inflammation, the systemic inflammatory response that we know essentially is highly prevalent in a lot of cancer, but particularly lung cancer, contributing to both tumorigenesis and also maintenance of the cancer state. So when we're thinking about cancer cachexia, these are the ESPEN guidelines of all these different sort of terms. But a good way to think about it is chronic disease-related malnutrition on a background of systemic inflammation. Okay, so disease-related malnutrition on a background of systemic inflammation. And a simple way I like to think of it is really it's caused by three things. It's anorexia, so patients don't have a good appetite. Physical inactivity, so patients are not able to do as much, they become weaker. And also this systemic inflammatory response, this inflammation. So these three things sort of combine essentially to give us what we see clinically as cancer cachexia. And I think we do need a bit of a change in how we approach this problem. What's done currently in oncology, predominantly, is that we stage the tumour. We spend a lot of time trying to, when patients present, working out what type of cancer it is. If it's a lung cancer, then looking at sort of subtypes of lung cancer, non-small cell, small cell, or even further differentiation of different types of non-small cell lung cancer, for example. We then look for the extent of disease spread, so the stage, whether we can do curative surgery or whether it's palliative chemoradiotherapy or palliative chemotherapy or immunotherapy. And once we've staged the tumour as much as we can, we then try to treat the tumour. And we pay less attention to the host. So I think what we need is really a new approach where we're staging the tumour, but we're also going to stage the patient. And we're going to look at the performance status because we know that really impacts on how well they'll do, and also their nutritional status. Now, quite often you will notice people have lost weight. They will tell you they've lost weight. You may even record it in your clinical notes that they've lost weight, but I don't think as much attention is paid to that, rather than just saying, oh my goodness, this person's lost some weight. So we're going to stage the patient as well, and once we've staged the tumour and staged the patient, we're going to, as well as treat the tumour, we should be treating the patient, treating the host, by optimising the nutritional intake, improving anorexia, improving their physical function, all with the sort of aim of improving the quality of life of our patients. And this was the ESPEN guidelines for cancer nutrition. These have been published a few years ago now. They've been cited nearly 3,000 times. And they, in their call to action, they call it here, we should screen all patients for nutritional risk early in their disease course, regardless of their body mass index. If somebody's heavy, doesn't mean they couldn't have underlying muscle loss, and regardless of their weight history. We want to increase nutritional assessment to include measures of anorexia, body composition, things like inflammation, and look at nutritional interventions with individualised plans for patients aimed on increasing nutritional intake, decreasing inflammation, increasing physical activity. In terms of that guideline I mentioned is a very long-winded one. We've just published an up-to-date one. It's far more manageable. So this is a practical guideline of clinical nutrition in cancer. I'm just going to spend the next few slides talking through some key points from this guideline, and this is where it's available. So it's free to access for anyone that you can potentially think about in your clinical practice. So these general concepts of treatment relative to patients with cancer. Firstly, screening and assessment. So the same way that, as I said, we're staging the tumour, we want to stage the patient. So detect nutritional disturbances at an early stage, evaluating the nutritional intake, working out how much they're eating, working out if the weight's changed and over how long the weight's changed. And if patients have abnormal screening, we recommend objective and quantitative assessment of nutritional intake, nutritional impact symptoms, muscle mass, and degrees of their physical activity or inactivity, and systemic inflammation. Now, some of these you'll need to involve your dietitian colleagues about that, but I think these are key aspects. If you screen something and you find something wrong, you need to act on it. In terms of their substrate requirements, well, a key thing here, even if they've not had weight loss, okay, even if they've not had weight loss, We recommend that total energy expenditure should be the same as somebody normally. So you're talking about between 25 and 30 kilocalories per kilogram a day. So that's basically like a 70 kilogram person taking about 2,300 calories a day. And if possible, of that calorific intake, we want to eat as much protein as possible, up to 1.5 grams per kilogram per day. That's a lot. And use supplements if necessary, and discourage the use of high-dose micronutrients. So we don't say specific supplements over and above what they would normally take. So they should get enough for a healthy diet. Essentially, we don't need extra vitamins and things. In terms of nutritional interventions, let's start with oral nutrition. We recommend nutritional interventions increase oral intake in patients who are able to eat. So dietary advice, going through a dietary history with them, what they eat, and trying to treat symptoms associated with their diet. So if you've got a patient with severe oral candida or pain on swallowing, or for example, they have a mucositis, that's going to influence how much they can eat. And that's an important part of treatment targeting these nutritional symptoms. If we are going to use, enteral nutrition, we don't use it very often. That involves, specific requirements you have to go through in terms of counselling and things. And it's really, only using a small proportion of people with lung cancer. So apart from, oral nutritional advice, exercise, we recommend maintenance or increased level of physical activity. Now you may say, if somebody's losing weight, why do we want them to exercise? Surely if they exercise, they will lose more weight. But actually what will happen is if people are eating well and a good calorie intake a day and they exercise, what that will do is those calories will be converted to essentially building up protein and muscle. So exercise along with a good dietary intake allows muscles to be maintained. If people just eat without exercising, all they do is gain fat mass, which we know is less useful. In terms of the drugs that we can use or we shouldn't be using, I think corticosteroids are a common one we'll see, and they can be used to increase appetite, but I would say they should be used for a small period of time with careful documentation of why they've been started, when they've been started, and stopping as quickly as we can, because they actually cause loss of muscle, which is something we want to stop happening. Again, progestogens can be used, but they can have side effects. So really, short-term use only. It's in these guidelines we recommend the use of fish oil supplements, so omega-3 fatty acids, which have both an anti-inflammatory effect and also have been shown to be helpful in patients with cancer cachexia. And also think about patients who've got early satiety when they're feeling full quite quickly. Think of prokinetics, think of treating constipation as well. Just at present, we don't recommend non-steroidals. We don't recommend cannabinoids, so there's insufficient data. But that may change in the future as trials are being done. Surgery, a lot of our patients will go for surgery. So it's key here that for cancer patients, they should manage within an ERAS program. And most hospitals now, particularly thoracic surgery, will be using an ERAS program. That's something that is strongly advised. And if it's repeated surgery, again, they should be maintained on an ERAS program. I think in some ways, probably the surgical colleagues have got this aspect a bit better than our oncology colleagues. So it's important really that patients are managed as well as they can, usually within the ERAS program. Radiotherapy, a lot of our patients will go undergo radiotherapy. Again, that can make quite marked differences to their ability to swallow and their mouth hygiene, etc. So try to maintain swallowing as much as you can and ensure adequate energy and nutritional intake. And we should only use parenteral nutrition if adequate oral nutrition is really not possible. Cancer survivors, thankfully we're seeing many more of these in our clinics, and we say that these patients should still participate in regular physical activity and avoid physical inactivity. So just as we're all told to keep exercising regularly, it's the same for our cancer survivors. And again, a healthy weight, a healthy diet, I saw somebody today in my clinic who was essentially cured of the lung cancer, but had lost a lot of weight, but was not back to the pre sort of cancer weight, and I encouraged them to try and eat a bit more and get their diet a bit back to what it was pre-condition. In palliative therapy, and that's a funny term now because I'm not really sure, what it means, but essentially patients who are being treated, with non-curative intent, we still want to manage them as best we can, and in these patients we'll maybe use steroids a bit more often, but in patients who I would say are dying in the last weeks to short months of life, then high dose prolonged steroids is probably a reasonable thing to do. So I'm going to finish here with some this Kaplan-Meier curve that was done in a study a couple of years ago, and it looked here at patients across the whole course of their journey. So you have some patients who will remain throughout their lung cancer journey but don't have cancer cachexia, and some will remain with cancer cachexia. But there's a group of people here who actually can convert to cancer cachexia, or will convert from convert from not having cancer cachexia to cancer cachexia, and that's what happens normally. So this cachexia status can change, and it quite often changes during the course of treatment for bad. They go from not having cachexia to having cachexia, but we can actually in a position to change that, to try and make less people converting from not having it to having it. In terms of my take-home messages for you all, firstly, look for it, and I mean really look for it. Ask patients about it. Don't just record their weight. Ask them how much weight they've lost. Ask them about their diet. Make the team aware that this is an issue for this patient. These basic interventions, optimizing dietary intake, simple exercise advice, are easy to do. Take 5 minutes in clinic. You do not need a dietitian to manage cachexia. And also think about optimizing the symptoms patients have. And this is a condition that affects not just the patient, but their whole family. So support the family, because they're some of your best allies in supporting the patient in doing this. And I think that managing cancer cachexia has the potential to truly maximise the effectiveness of treatment of thoracic malignancy. And I think there's a bit of a way to go before we get to that point. So thank you very much for your attention.
Thank you very much, Barry. It's extremely clear. We have overrun a bit, guys, and I appreciate that. So I'm just going to limit it to one question each, and I'm hoping our audience might just hang around for another couple of minutes. Rachel, if I could just ask you about your fantastic service, which I'm extremely envious of. We don't have that kind of service where we are, which is very sad. Short of me coming up to Edinburgh, which is a long way to go. How, without wishing to be rude to colleagues, how specialised is what they do? Because is this something which requires a very complex multidisciplinary team like you've got, or is this something that in fact people on the end of the line might be able to serve in their own hospitals with an engaged anaesthetist? How did it all start?
So I only joined the service in 2016, so just been there for about 5 years. So it was very well established when I joined the team, but it is a very specialist service, I suppose. And I think what makes it work is the multidisciplinary approach, and the fact that we all work well. All our specialties come together to provide that service for the patients. In particular, I think what works well is having the input from the chronic pain doctors as well. Bringing their expertise and their kind of knowledge of kind of different ways of managing cancer pain, rather than just purely kind of a palliative medicine approach to it.
Did you see this more as a kind of regional specialist service as opposed to something that one could set up in any hospital? Because that sounds like that's what this is.
Yeah, I would say it's much more of a kind of regional specialist service. As I say, we cover the kind of west of Scotland at the moment, but we do take referrals from outside the areas because we're a very unique service within Scotland and within the UK, really.
And can I ask, in terms of referral, what kind of referral guidelines do you have? Are you saying to people that you should only be referring to you guys once they've been seen by a palliative medicine physician or pain specialist, and only then, if pain is uncontrolled, do they come to you, or are you getting referrals from the
It's very mixed. So we used to be purely palliative medicine referrals to the service, but we did, with being in the cancer centre, that did kind of limit. Obviously, oncology colleagues were having patients who they had difficult pain. So we do receive referrals now from oncology colleagues, but we would very much then kind of check out whether they had local palliative medicine involvement and kind of try to do a kind of baseline palliative medicine assessment before appointing them to clinic. But yeah, the majority of our patients come via a kind of local palliative care service into our service.
Thank you. Really helpful. We've got a question from Tony Duffy for you. Is there any evidence to support the use of other opioids for breathlessness, in particular oxycodone and fentanyl, if morphine is not tolerated?
Yeah, a great question. The answer is there isn't evidence, but from first principle, for sure. If a patient, tolerates an alternative opioid better than morphine, then from first principle rationale would be absolutely. So it would be a case of starting off with very low dose oxycodone in opioid naive patient, or if it were fentanyl, that it would need to be very carefully done. So yes, the answer is definitely yes.
Another question, which is, I love the idea of the stud and the acupuncture needle. Question here above other approaches, which is often our therapy colleagues recommend, such as the handheld fan. I appreciate the evidence is going to be not particularly robust, but what's your view on those other approaches?
I think with any symptom, we have to take a very broad approach, and just think of yourself. If you were feeling stressed and anxious and you haven't been sleeping, you're totally fraught, any physical problem is going to be exaggerated 100 times. Yeah. And I think anyone that thinks we can manage these problems by just a pharmacological approach is wrong. And that's where we're much more likely to run into drug toxicities. So actually having a multifaceted approach, we have absolutely convincing evidence from fMRI work that anxiety and mood will really impact on physical symptoms, breathlessness and pain, most definitely, and some very sophisticated work looking at manipulation of that. So anything you can do to lessen anxiety, improve mood, improve sleep, will automatically have a really positive input in this interaction between the different networks. I think if you think of the brain like a subway, an underground map, and you want to get to the end point, you think, okay, how do I negotiate that? That's really the way to look at it. And, understanding patients and helping them to understand their symptom and giving them control and teaching them about breathing and empowering them is actually, the time spent on that is as important as the time spent explaining how to manage the side effects of opioids or opioid titration. It really has to be a sort of dual approach. So anything to relieve anxiety, anything that deals with peripheral opioid receptors, potentially, the evidence around handheld fans, breathing work, acupuncture needles, all of that is very challenging. But I think over the next 10 years, we're actually going to be much more sophisticated in the way in which we can look at these in the research arena. And we will have a better understanding. But I think right now it's looking at your patient and saying, okay, in this patient, what can I actually do to minimize their anxiety? Because by doing that, I'll improve the breathlessness.
Thank you very much. And Barry, finally on to you about cachexia. I thought it was absolutely fascinating. I just recognise how badly I do that in my patient group, I'm ashamed to say. Question from Dr. Anonymous. As steroids often lead to weight and appetite stability, whilst underlying muscle loss is still happening, how can clinicians recognise this? Another question is fatigue diet related? So the steroids, that's an interesting conundrum, isn't it?
Yeah, there's not strong evidence for steroids what we know is that they can have a short-term effect in terms of increasing appetite and also a sense of well-being. So we know that. But longer term, they have quite marked side effects. And I would argue, if you were to look at any patient you've got on a dose of steroids for greater than 4 weeks, look at their quadriceps and look how much muscle they've started to lose. So they really are. They're sort of in some ways can be our best friend, but actually, hidden behind that, there really can be an enemy. So cautious use of steroids, I would say. We're not doing trials on them at the moment, Tom. They're not something that I think, other than a sort of brief symptomatic benefit, they should be part of our regular armamentarium. They have their place, as you'll know, for short-term side effects of therapies, but not in terms of sort of longer-term, maintenance for it. They're pretty much a blunt tool, and there's better ways to target inflammation than doing the steroids. In terms of fatigue, sorry, Tom, could you just repeat that question to me, please?
Okay, what I might do is slightly switch to a different question, which I thought your last comment was really good. You said you don't need a dietitian to do this. And the first 15 minutes of your talk, I was thinking, I've got to speak to my dietitian to get this better. So I then felt really guilty. I thought that. It is. When I'm sitting in clinic, this incredibly important part of what we do, I completely miss out on. I don't have the capacity to do it. Everyone's running around. It should be all of us, but in reality, practically speaking, how can we begin to better assess our patients and implement the excellent guidelines you've done? Does that fall within the palliative medicine team? Should it be within the CNS role, or should we all be doing a bit?
I think it's all our bit. I mean, I think by the time palliative care are involved in these patients, the ship is well and truly sailed. The amount of patients I see who are started on nutritional supplements when they've got profound refractory cachexia, there's no point at this. All you're doing is making somebody drink pretty unpalatable drinks near the end of life. So I think it really comes down to all our jobs, Tom. I'm lucky if you've got a dietitian there. I'm very envious of that, because we very rarely see our dietitians in the lung cancer clinic. But I think dietitians can do specialist advice, but quite often it's just getting the basics right. So acknowledging that they've lost weight, and not just writing it in a letter saying they've lost weight. How much weight have they lost over what period of time? And then brief counselling on, tell me about your average day. What do you eat? And then simple advice. And I always say to my patients, we're going to tell you to do all the things that we've been telling you all your life not to do. So all the foods that are high in calories, high in fat, that are high in energy, we want you to have them, because things like cheese, chocolate, crisps, these are all energy dense foods, but also to increase your protein intake and things like some small meals regularly. And I think getting the family member on board with this, to say this is part of their cancer treatment, this is part of the treatment that's going to help you fight the cancer, is important. The exercise bit, it's not an exercise bike, it's not a rowing machine, it's not a Zumba class. It's just going for a brisk walk for 15, 20 minutes, 3 or 4 times a week. And that can be something that's done with family members. So I think, I've just told you that in 2 minutes. Various members of the teams could take that in, and I think just, taking it on board. And I know our CNSs spend a lot of time with patients. They're often, sad to say, much better at this than doctors are. So I think, they'll be a good, person, but I don't see any reason why you couldn't train, auxiliary health professionals to do this sort of work as well. So if I had the money, that's what I'd have in my clinic. A really motivated, healthcare, auxiliary nurse to do this with the patients.
Thank you very much. Thank you also, Rachel and Marie. If I could just have the last BTOG slides up, that would be great. Last comment from another Dr. Anonymous. Great session. Loved treating the host. Tumours rarely walk into the clinic without a patient wrapped around them. Holistic patient care needed for better quality of life. I think we would all agree with that. I did want to go on to the last slide. I don't know if we can show those, just about the next BTOG sessions coming up, but maybe we don't have those. So we don't have those. So instead, I will thank everyone for staying a little bit later than planned. Thank my excellent panel for their input. I'm going to go back and review my service and work out how we can do things better. And thank you very much for joining us this evening. Have a nice night.